MRI and MRI-guided prostate biopsy has revolutionised the diagnosis and staging of prostate cancer. Dr. Swindle is a urologist and an expert in MRI of the prostate and MRI-guided prostate biopsies. He obtained a Masters of Surgery degree on magnetic resonance of the prostate at Sydney University. He performed 2 years research on MRI of the prostate at Memorial Sloan Kettering Cancer Centre in New York and has been involved as a co-chair in multiple prostate MRI masterclasses throughout Australasia.
MRI has been around for a long time, but MRI of the prostate has only really been shown to have clinical utility over the last few years and really has revolutionised the diagnosis of prostate cancer. Previously, when prostate cancer was suspected with an abnormal digital rectal examination or an elevated PSA, either a transrectal ultrasound-guided prostatic biopsy or a transperineal ultrasound-guided prostatic biopsy was performed. The issue with these two procedures is that the prostate cancer cannot be accurately visualised and the whole prostate is biopsied blindly. Not infrequently, if the cancer is small and peripheral or alternatively in the anterior part of the prostate cancer would be missed with these two diagnostic procedures. These MRI images demonstrate what a prostate cancer would look like. We can see here the outline of the prostate, and if you look here in the peripheral zone of the prostate, you can see a dark area. That is suspicious for prostate cancer. You can also see on different imaging sequences, we can see a dark mass here, and on another sequence we can see a white mass. By combining all of these factors, we have a very high index of suspicion that this is actually a prostate cancer. By doing an MRI of the prostate prior to performing a biopsy, we get an idea in the first instance of the size and location of the lesion, and this can enable us to make a decision as to the best way to biopsy the lesion. It essentially gives us a roadmap as to how we biopsy that lesion in the individual patient. This flowchart demonstrates how we would use the MRI findings to make a decision. If a patient had an elevated PSA, then went on to have an MRI which demonstrated a suspicious lesion, we could biopsy this lesion by one of two techniques. If a patient had a small lesion in the prostate or an anterior lesion, then it is possible that the cancer could be missed with standard biopsy techniques. In this situation, we would decide to perform a targeted MRI-guided prostate biopsy to ensure that the area of interest was accurately targeted. If there was a large peripheral lesion that was easily visualised and therefore easily targeted, then a standard transrectal ultrasound-guided prostatic biopsy or transperineal ultrasound-guided prostatic biopsy could be performed. MRI of the prostate also has the potential to spare men from unnecessary prostate biopsies. In the past, essentially all men with an elevated PSA underwent a prostate biopsy, and a significant proportion of these men didn't have cancer and therefore underwent unnecessary biopsies. MRI now gives us the ability to spare some men from prostate biopsies. If a patient has an elevated PSA and an MRI shows no abnormality, then some patients can be spared a biopsy. All patients are assessed on an individual basis, taking into consideration the absolute value of the PSA free to total ratio, the prostate health index, the family history of the patient, the age of the patient, and the size of the prostate. Using all these parameters, we can decide who can be spared a biopsy. If we have an older patient with a negative family history, a stable PSA, a high free to total ratio, a low prostate health index, and a large prostate with a negative MRI, these patients have a low risk of prostate cancer and therefore can be observed and can be spared a prostate biopsy. Unfortunately, MRI can't detect all cancers, as some cancers are MR invisible, and therefore a negative MRI does not totally rule out prostate cancer. If we have a young patient with a positive family history, a rising PSA, a low free to total ratio, a high prostate health index, and a small prostate, this patient still has a significant risk of prostate cancer despite the normal appearing MRI. In this situation, it's not safe to observe the patient, and a standard transrectal ultrasound-guided prostatic biopsy is performed because MRIs in this situation can miss up to 31% of cancers. I think that MRI of the prostate has really revolutionised the diagnosis and management of prostate cancer and is one of the most significant advances in prostate cancer management over the last 25 years. For the first time in many years, we've actually been able to see the tumour that we're dealing with, which has enabled us to know how to most accurately diagnose and therefore treat the cancer. It has also enabled us to decrease the number of men that undergo unnecessary prostate biopsies, and by adding MRI into our management algorithm, it has decreased the number of clinically insignificant cancers that are detected and that will never affect a man's lifespan and therefore don't need to be treated. MRI has revolutionised the way we currently manage men with prostate cancer.